Good morning, everybody. Welcome to the second session at the Ionesco University that is run virtually. We've got the Sublobar resection session, and we are privileged to be joined by eminent group of chairs and speakers equally. I would, first of all, it's my honor to present my co-chairs, Mr. David Waller, who was my teacher as part of my training, consultant thoracic surgeon at Barts, Mr. Sean Barnard, consultant thoracic surgeon from Newcastle. I'm not sure whether it would be joined by John Pilling from Guy's Hospital. I will hand over the chair to Mr. Waller to present our first speaker. To you, David, if we can hear you well, I hope.
Thank you, Hazem. It's my pleasure to co-chair this exciting session, which of course now is extremely topical. And our first speaker is Professor Peter Licht from the University Hospital in Odense in Denmark, who is a good friend of mine and is a very high officer in EACS. I believe is the next president of EACS. He's an interest in minimally invasive surgery. And we'll be talking about the evidence for sublobar resections. But please bear in mind that Peter will have recorded his talk before the recent presentation of the JCOG 0802 trial at AATS. So please bear that in mind. He may refer to it, but he hasn't seen the results. So over to Peter for the first presentation.
Good morning, ladies and gentlemen, dear colleagues. My name is Peter Licht. I am a thoracic surgeon in Denmark, working at Odense University Hospital. It's a great honor to participate in this distinguished meeting. I've been assigned a topic on the evidence of sublobar resection, which I interpret as the evidence of sublobar resection versus lobectomy for early stage lung cancer. Bear in mind that sublobar resections cover a variety of surgical interventions, from a enucleation of a peripheral tumor, which is now obsolete for lung cancer, to a wedge resection, which is a very simple procedure, particularly in small peripheral nodules, so easy that it can be performed by non-thoracic surgeons, which is probably why it is so frequently used. Anatomical segmentectomies are far more complex, whether you remove one segment or do a bi or a tri-segmentectomy. These are much more challenging. Personally, I think they're more challenging than a lobectomy. And I will be a little bit provocative early in the morning by stating that I believe that the majority of thoracic surgeons are not capable of doing a good anatomical segmentectomy in every segment. The standard of care for surgical resection of lung cancer has evolved over time. It's a moving target. In the beginning, pneumonectomy was the standard of care, 5 decades of lobectomy, and now for the last 10, 15 years, we have discussed issues about small lesions that are detected incidentally on trauma scanning or by screening programs, where reports now show excellent long-term survival. And a sublobar parenchymal sparing procedure is relevant, considering that a substantial number of our patients will develop a new primary over the years to come. So the question remains, is a sublobar resection an adequate operation compared with lobectomy? First done more than 70 years ago for bronchiectases, almost 50 years ago for carcinoma, and 1973, Gensic published the first case series on 123 patients with pretty good 5-year survival of 56%. Interestingly, he was able to follow the same cohort and report on 10 and 15-year survival in 1987. Others reported on segmentectomies, and soon it became apparent that there was an issue with local recurrence rate, which seemed to outnumber lobectomy by far. There are one paper I was able to find where lobectomy recurrence rates was actually higher than segmentectomy, and these issues probably fueled the desire for a large prospective randomized trial, which was conducted by the Lung Cancer Study Group, led by Robert Ginsberg from Toronto, where they did intraoperative nodal staging before randomizing into a lobectomy or a sublobar resection, which could be an anatomical segmentectomy or a wedge resection at the discretion of the operating surgeon. Overall survival curves separated after 4 years, and disease-free survival curves were significantly in favor of lobectomy. So Robert Ginsberg concluded that due to the increased rate of local recurrence, increased rate of death rate and cancer death rate, the anatomical lobectomy should be considered the treatment of choice in the future. But since then, there's been a lot of critique of this trial. First of all, it's an old study done in the 80s. It was underpowered for survival. Diagnoses of lung cancer were made on simple chest x-rays performed for symptoms. Very few patients had a CT scan. No patients had a PET scan. We have no data on the pulmonary function. They allowed tumors larger than 2 centimeters to be included. Recurrence was detected by x-ray, and it took 7 years to recruit 276 patients. In addition, there's been some statistical debates because they designed the trial with the assumption that lobectomy was superior, thereby using a one-sided test with a high significant level alpha of 0.1 instead of the more traditional modern 0.05, meaning that the overall survival difference in this trial of 0.008 would not have been considered a statistical significant finding. And since then, times have changed. We now have screening programs in many countries detecting small nodules, small peripheral tumors. We see better with the modern imaging, high-resolution scans, PET scans, and we have better staging modalities. In addition, we all have better surgical technology available using VATS or robotics, and stereotactic radiation may become a player in the future. And we all know that segmentectomies can be an appropriate operation for some patients with poor lung function, other comorbidities, and in patients with carcinoids and ground glass opacities. So after the lung cancer study trial, we have seen a number of papers emerging in the literature showing an equal or similar disease-free survival between lobar and sublobar groups. And we have overall survival curves that are similar between the two groups in patients, in subgroup of patients elder than 70 years. And we have seen the literature accumulating papers in favor of lobectomy and others in favor of a sublobar resection. And this probably fueled the interest for a renewed randomized trial comparing lobectomy with a sublobar resection. And actually 3 such trials have been conducted, and all 3 have closed. The 2 top ones from the Japanese Cancer Oncology group, where they randomized patients with a solid tumor into an anatomical segmentectomy versus a lobectomy for T1A tumors, meaning less than 2 centimeters, and another trial addressing specifically ground glass opacities, which appear to be much more frequent in the Asian population. The North American trial accrued 700 patients, and they allowed a wedge resection in the sublobar group. The safety data has been published in the trials, but we await the overall survival and disease-free survival desperately before we can make any solid recommendations what should be the standard of care in the future. In the meantime, we will see non-randomized papers continue to emerge. We are now seeing papers using propensity score matching, which is a fancy statistical method to adjust and make 2 non-randomized groups more comparable before analysis. And we see that using this technique, survival curves are very similar, both overall and disease-free survival in this paper from the Pittsburgh group. We are seeing meta-analysis emerging. I've been able to identify 8 meta-analyses on this topic, and they all disagree about the conclusion. So you can more or less choose the meta-analysis that suits your own beliefs. This one is from British Journal of Cancer 2005, looking at 14 papers and concluding that survival after a sublobar resection is comparable to that of a lobectomy. We are seeing papers with outcome from large population databases such as the North American SEER database with more than 14,000 patients, concluding that lobectomy remains the better operation for non-small cell lung cancer. This is confirmed in more recent meta-analysis. This one is Chinese that look at 24 studies with more than 11,000 papers. For stage 1 lung cancer, they concluded that sublobectomy yields a lower survival compared with lobectomy, but quite interestingly that a segmentectomy is a comparable procedure to that of lobectomy for stage 1A disease. Another Chinese with even more patients and more studies found the same, that lobectomy yields the better survival than segmentectomies, but quite interesting in this meta-analysis that wedge resections are not inferior to an anatomical segmentectomy. So you can choose whatever meta-analysis that suits your own beliefs. The most recent one concluded that there's no difference between a lobectomy and a sublobar parenchymal sparing resection. So why are all these studies showing different results? Quite simple, because of different case mix, comparing apples with orange regarding size, type, margins, types of procedures, whether adjuvant brachytherapy was used, whether they operated on patients who could have tolerated a lobectomy or patients who had poor pulmonary reserve or comorbidities. And then there's an issue about the lymph nodes. Let's take one at a time. This size was shown to be an important factor for T1 tumors, where they subdivided patients into those with a diameter of less than 2 centimeters, meaning T1A and T1B, or T1C with a diameter up to 30 millimeters. The survival curves separate for the T1C tumors, but remain the same in the two groups for the smaller tumors. Another important issue about size is the risk of local recurrence. In a Japanese paper from Lung Cancer 2009, T1C tumors appeared to have a much higher local recurrence rate when a sublobar resection was performed. Tumor type certainly also influences. An adenocarcinoma is no longer an adenocarcinoma. We've learned over the last decade that there are subtypes of adenocarcinomas that have different biological behaviors. So it's no surprise that if your case mix in any report differs between a lipidic and a solid tumor, that would influence outcome. Illustrated here in these Japanese series by Nakayama, where 46 had a lipidic adenocarcinoma and 17 a solid, showing a marked difference in 5-year survival and local recurrence rates. Resection margin has been a very hot topic. The Pittsburgh group analyzed the data and found that if the margin was less than 1 centimeter, there was a significantly higher risk of local recurrence. This was also found in a large prospective study from Japan, where on multivariate analysis, the only predictors for survival was the tumor size and the margin. Perhaps more relevant, it is to look at tumor to margin ratio. This paper analyzed 27 patients with recurrence and noticed that in 23 of the 27 patients with recurrence, the tumor margin ratio was less than 1. Also, the case mix of segmentectomies versus wedge resections appear to influence outcome profoundly, except in this paper from New York, where the Al-Toki group analyzed almost 300 patients and did not find any significant difference in overall survival. All other studies have found that segmentectomies outperform wedge resections. In this Japanese study, in almost 2,000 patients who were all able to tolerate a lobectomy, the segmentectomy was superior. This is also found in Chinese studies where segmentectomies outperform wedges, but at the same time, lobectomies outperform the other sublobar resections. Same message from this propensity score match study from the Polish lung cancer registry, where lobectomy appears to be the superior intervention, followed by anatomical segmentectomy and then a wedge resection. Lastly, a large study from using the SEER database, again propensity score matching, showing that segmentectomy should be the preferred technique if you insist on doing a sublobar resection. Adjuvant brachytherapy was hot 25 years ago. Patients, after reports that patients had profoundly reduced local recurrence rates if you embedded the suture lines with radioactive iodine. These findings were confirmed by Santos and Krish Fernando in subsequent publications, but everything stopped after the proper multi-international randomized trial, where they found absolutely no influence on overall survival or local recurrence rate, whether or not you used brachytherapy. Intentional compromised patients, I touched a bit about it, but it's important. And to make a long story short, here is a systematic review and meta-analysis where they really scrutinized the literature and concluded that a segmentectomy may be a feasible alternative for selected patients who could otherwise tolerate a lobectomy. Otherwise, sublobar resection should be reserved to compromised patients. You can do a segmentectomy if the tumor is less than 2 centimeters, located peripheral, or if it's a ground glass opacity. Bear in mind, these are non-randomized data, and they will certainly be influenced by the results of the 3 randomized papers I mentioned earlier. Finally, a word on the lymph nodes, which is attracting a lot of attention in the literature. To be precise, lymph node dissection should be a mandatory part of any sublobar resection. The data are obvious. Here, a study from the Turkish group in New York, where they analyzed 196 wedge resections, and assessment of lymph node had a profound impact on survival. Same thing was discussed by Daniel Buffer and the Yale group, where they noticed nodal stage migration due to nodal upstaging being an important factor. And we echoed the results using the Danish Lung Cancer Registry and noticed nodal upstaging in almost 1/5 of our patients. So certainly a proper lymph node dissection should be part of any resection, whether it's a lobectomy or a sublobar resection. The last trial, the last paper on this topic, analyzed N1 station and found positive N1 nodes in 14% of the patients. Mediastinal lymph nodes are equally important in sublobar resection. This paper is more than 25 years old, and we are all aware of skip metastases, so proper mediastinal lymph node dissection should be an integral part of any surgical procedure for lung cancer. I will end my talk with using the key points from Okada's paper, that from an oncological viewpoint, in sublobar resection, segmentectomy appears to be superior to wedge resections for cancer treatment. It's very important to discuss separately whether or not you are doing a sublobar resection intentionally or because the patient has compromised lung function or comorbidities. So a lobar resection could be considered an alternative for T1 tumors 2 centimeters or smaller, even in low-risk patients, but the randomized trials may shed some more light on that. And I would add to the conclusion that standard surgical resection for lung cancer is a moving target, and we haven't settled the discussion yet. We're awaiting desperately awaiting the 3 randomized trials, and until we have that result, the evidence shows that the gold standard remains a lobectomy with proper lymph node dissection. We should all be aware that stereotactic radiotherapy may become a key player in the future, and that oncologists may take over early stage lung cancer. And with that, I want to thank you all for your attention, and I wish you all a very good day.
Peter Licht for this very comprehensive review of the literature of the limited resection. Well, just a quick reminder to everybody, please use the opportunity of Slido to put in all the questions you might. The Q&A will be right at the end of the session. We will try to go through them. We have next is Mr. Kelvin Lau, who is a pioneering surgeon and the clinical lead for thoracic surgery at St. Bart's in London. He's been at the forefront of innovation with extensive experience in maximal usage of image-guided thoracic surgery with hybrid theaters, navigation bronchoscopy, and I think we are lucky to have him talking to us about the perioperative planning and localization of this complex and sometimes difficult condition. Over to you, Calvin.
Thank you very much for inviting me to talk about perioperative planning and localization of small lung nodules. These are my disclosures and the disclaimer for this talk. So the problem of nodule localization comes because the kind of nodules we see these days as thoracic surgeons are very different from the nodules that have been seen, say, 10, 15 years ago. No longer are there the 1-2 centimeter solid nodules you see on chest X-ray. Because of the number of CT scans people have, we pick up lots of incidental nodules. And with the implementation of increasing number of lung cancer screening trials in different regions, a lot of nodules which are subsolid, small and deep in the lungs are being found. The difficulty for us surgeons is when we resect them, how do we identify them? So in that, sometimes the nodules which are on the surface of the lung are easy to find, but you can, for the smaller ones that are difficult to palpate, it can be quite difficult. And then the question is, when you put a stapler down it, sometimes the lesion pops down to the other side of the stapler, so they can be quite tricky to coordinate. And with the advent of robotic surgery and robotic lung resection, it becomes even more difficult because you're one step further away from the patient and the nodule. You can't put your finger in and try to find it. And we end up with this scenario where I'm scratching my head thinking, where is this nodule? You don't want to do a big operation only to find that you've missed the nodule or you're right on the nodule and stapling through the nodule. So what I'm going to talk about this talk is how we use localization and perioperative planning techniques in order to find a nodule if you want to wedge resect it for frozen section, for diagnosis, or for metastasectomy. And these days, with small nodules, we're doing increasing number of segmentectomies. How do you assure that you have captured the nodule in your segment and you've got an adequate margin? Historically, lung nodule localization is done usually in conjunction with the radiologist. You send your patient down to the radiology department. They put a needle in percutaneously into the lesion. They can do a range of things. They can put a hook wire in, usually a breast hook wire, not designed for the lung, or they can inject dye. They can do all sorts of things. But then the patient needs to come up to operating theater. They need to wait for your case to finish and then come into theater for you to do the procedure. Now, because you've got a percutaneous approach, you frequently come up with a problem of a pneumothorax. So whilst the patient's going up the lift from radiology to your operating theaters, they're developing an increasing pneumothorax, they're getting more and more short of breath. In the meantime, as the lung is collapsing, it pulls itself out of the lung, the wire, and so you end up, the wire's no longer in the lesion, and you end up with a pneumothorax, you've got blood everywhere. You might find a puncture hole, but there's no assurance of the depth of the lesion, and so it's not a convenient move. To me, it's also a waste of time of the radiologist. A radiologist is much better reporting more planning scans to give you more nodules rather than wasting the time trying to coordinate that day around your operating schedule in order to plan a procedure. So why not do it yourself? This is why I wanted to do it myself, a DIY kind of nodule localization. I don't want to have a percutaneous approach puncturing the lung, puncturing the pleura, so I do endoscopically. So this is what I aim to do, put a bronchoscopy down, use navigation bronchoscopy to navigate out to a nodule, and then do what I want with the nodule to mark it. And that's going to be the subject of my talk today. So before we talk about nodule localization, I'll just give you a background of the technique I use, which is based on navigation bronchoscopy. Essentially, when you use bronchoscopy, you have no idea how, all through the whole airway, how to get to a nodule way over there. Navigation bronchoscopy allows you to navigate with this little small channel all the way out to the nodule. And then when you get to nodule, you can do whatever you want. In practice, how does this happen? What you do is you load a patient CT scan, you identify the location of the nodule, just like you would with your GPS. You tell the computer where your destination you want to get to is, and the computer automatically finds an airway path to it. Here you go. So it gives you the airway path on the right with the global map, and it gives you the bronchoscopic view on the left. So you see the virtual bronchoscopy as if you're driving the car, you can see what's in front of you on the road and what the landmarks are. On the day of the procedure, you'd walk around the airway, and then this computer very cleverly overlaps your airway path onto the CT, so you can now change so that you can navigate on the CT. And all you do is you follow the path, just like when you drive your car with your sat-nav. Here you go. So when you're in the proximal airway, central airway, you can see out through your bronchoscope, then you just literally follow the purple line. You can see there's a secondary carina here. So what you do, it tells you to go below it. So you go below it, you go into this hole. At some point, your bronchoscope will be wedged. You can't see anything and you can't go any further. But this is the bit where you then advance the extended working channel out and you navigate through the CT because, of course, we've matched the CT to the location, to the patient already. So here, it tells you there's a bifurcation and to go right. So you go right. And bingo, you arrive at the nodule. And the advantage of this is you can do multiple nodules. Lung cancer screening picks up multiple nodules. Very rare do patients have just one nodule. And so you can biopsy all those nodules. You don't need to worry about multiple punctures and bilateral punctures and getting bilateral pneumothoraces. Biopsy away and do what you want to do, as I will show you later, for resection. So what I do in order to help me localize, what I would do is I would try to do some form of marking. And I started off with dye marking first because it sounds easiest. It sounds like a natural extension of what people do percutaneously. So here you can see the ground glass opacity is quite proximal, and I've set my target to be the subpleural, just below the pleura on the near to the surface of the lesion. And I navigate out to this new target, and then I just inject some dye. So I'm going to share with you my story of how I went from that to what I do today. So that is what we end up with. So we end up injecting some dye. This is a beautiful picture of dye marking in someone with relatively healthy lung, clearly hasn't lived in London all their life. And you inject some dye and it tells you that the ground glass opacity is just beneath that lesion. Easy. The reason why I put this picture up to show you is because it's probably the best case I have. I wouldn't go and show you a case that didn't work. The segment, if I want to do a segmentectomy, such as a posterior segment of right upper lobe here, then it's easy to decide where to put the intersegmental plane as well, because you could mark the lesion and you can then determine how far to take your intersegmental plane. Remember, sometimes we're not really interested in the true intersegmental plane because lesions rarely lie in the center of a segment. What you want to have reassurance is the margin after you do the resection, and this kind of localization help. But dye marking isn't perfect. This is more often what I see, the river of blue. So as you imagine where you inject a dye, you're just a pleural. It doesn't take very much. You have a very small window of opportunity to localize the dye. Otherwise, you do a pleural puncture, and then you end up injecting dye into pleural space, and you get blue everywhere. But this picture here also illustrates a number of other problems. It doesn't work when there is lots of adhesions, because by the time you've taken your adhesions down, it's blue everywhere. It doesn't work if the lung is anthracotic, like if they've worked in the mines all their life, then blue on black is just nigh on invisible to see. So I knew this was a problem, and so what I started doing was, apart from relying on dye, which might spread, I'd inject something that won't spread to localize the surface of the lung. And so you might just be able to see here, at the same time as injecting a dye, I put a little metal hook fiducial here. So I could still tell from here that that is the position where my bronchoscopy have reached, and it doesn't matter that the dye has gone everywhere. And so I started doing these two things. But that didn't work either very well, because we're still working very close to the pleura, and you're pushing something out from just underneath the pleura. And here it's a beautiful fiducial marking of the mediastinum. So this fiducial have gone out and inserted itself into the mediastinal fat, which is clearly not what I was planning to resect. So to me, this is a problem of surface localization. And surface localization also gives me another problem. I know where the surface of the closest point of the lesion is, but I don't know where the lesion is deep. And so I'm not able, when I put my stapler down there, I know it's there, roughly, but I have no idea whether I'm clear of the lesion. I haven't squashed and closed my stapler with the lesion still below it. And if I've got the lesion in the right place, when I have my stapler, how far is that margin? Let's say we're doing a metastasis. So surface localization limits you to a relative position, but does not give you confirmation of the absolute position of the lesion. So what I started to do is to one step advance the point about putting a fiducial in. Rather than fiducial marking the surface of the lung, make it easy, mark the lesion itself. You've biopsied the lesion, you pop a fiducial in. So here you see I've done exactly that. I put a little gold seed marker into the lesion, pop, there it is. And I do this in a hybrid theater so I can see everything. So effectively, a hybrid theater is a C-arm that does CT scan. So there we go. That's capturing the image, and then I can have instant confirmation that my fiducial localizes the lesion. And I can also see that my fiducial marks the slightly more inferior aspect of the lesion here. So I know I need to move slightly back away from the lesion to do the wedge resection for this metastasis. And then it's very easy. The patient's already on the table with a CR. You turn the patient into lateral position. And then here, I can do a single port VATS wedge resection, and that's very straightforward because I don't need to worry about putting a finger in to try to find this tiny lesion amongst the lung and then putting a stapler and putting all these things into this tiny hole. I don't need to make a second, third port. I can very quickly, almost instantaneously, find the lesion without a finger in. So this is what it is. So this is the fluoroscopy on. It shows the lesions being captured by the curve of the forceps with a margin, and so I can very happily then just slide my stapler in through this one same hole with no worry that the lesion is not there. And off we go to staple it. I'm clearly fiddling around a bit. So this is the end product of what you want to see. You want to have completed a wedge resection, and you know you've captured the nodule and you've got a margin away from your staple line. And the exciting thing about this is apply this to robotic surgery. And this is what something I have to credit Sasha Stamankiewicz for doing. And we've done this together in order to solve the problem of nodule localization, especially in segmentectomy, which is what the robot is very well designed for in order to do. So how do we do a segmentectomy for these tiny lesions which are difficult to find, impalpable, with no haptic feedback, and be assured that your segmentectomy has a clear margin of away from the lesion, and that you've captured the lesion? As this is more important because, of course, this week we saw the JCOG reporting, and so I think there'll be a lot of discussion about this, about survival versus recurrence. But I think segmentectomy, by the looks of it, is here to stay and has a role for small lesions. Again, the problem of lack of haptic feedback is a problem for segmentectomy, and so what we do is we combine my two favorite toys together, which is the robot and the hybrid theater. So I'll show you two cases. I think these two cases illustrates what we do quite well. So the first case is a 49-year-old female who has never smoked with a history of breast cancer. For her breast cancer follow-up on her 4th year scan, they found a new 7mm deep right lower lobe nodule. So here it is. Very inconveniently placed nodule, if I might add, for resection. You can also see here, I made a cut here so that you can see this medial segment bronchus. The posterior segment bronchus comes up a little bit higher, so it's down here. And this is the anterior and lateral segment bronchus. So you can see it's sitting between the anterior and the lateral segment bronchus. And this is also quite an interesting thing to show you. So we think about segments and nodules from the surface of the lung. But when a nodule is very deep, the distance between two segments, between two segmental bronchus, is so close that you can't do just one segment and have the margin, because before you hit the margin, you're already onto the segment bronchus. Look at how close these two segmental bronchus are. So you can separate the segments out in your head if you go laterally, but you're likely to need to think about multiple segments. This one sits between the anterior and lateral segment bronchus. And you know, she is kind of medically trained. She is a medical virologist. She is a lab virologist. But the problem is she was not happy to accept this as a diagnosis of breast cancer metastasis, and she wanted tissue diagnosis. And so she came to me for navigation bronchoscopy. So here we are. We did the navigation bronchoscopy. It took a bit of time wriggling out to that nodule because such tiny nodules, to get the precision is quite difficult. Anyway, there we are. There's the channel abutting the nodule, and we biopsy it. And the histology came back, and she was right. This is not a breast cancer metastasis. It came back as a neuroendocrine tumor, with a Chi-67 of 5%. So this is possibly a carcinoid tumor, possible a neuroendocrine tumor of other sort, but is not a breast cancer metastasis. So we need to think about what to do. She wants it out, but conventional stereotactic radiotherapy and so on for metastasis might not be the right thing anymore. So we wanted to do resection, and of course, fortunately, with my channel there, we pop a fiducial in. So there you go. There you can see the metal fiducial next to the lesion, lying next to the lesion, beautifully localizing it for it. From unable to see it, feel it, or anything, it is now visible. So this is our setup. We have a C-arm. You see draped C-arm around the patient, and then we have Al, our registrar, assisting with the robot, and behind it, you can see the fluoroscopic setup there with our radiographer, relatively easy in the sense that it doesn't really change what we do much, except that you now got a view. So the first thing you do when you go into is to actually figure out roughly where in the lung is this nodule to help you. If you got it in your head, you can then do the resection. So we put the two robotic arms there, and then we turn on the radiographer. We see radiology with the fluoroscopy, and you can see you've got the nodule roughly between yourself, and you know which part of the lung you're operating in. So you can then start your hilar dissection, divide your A89, your B89, and your veins, and so on. And that doesn't really matter about the resection, because what we're concerned about is the parenchymal margin is away from the lesion. So when you come to, after you've divided the hilum, then you put your stapler in for the parenchymal margin. And this is the first position we ended up in. And you can see the fiducials on the wrong side of this parenchymal staple line. And so if you didn't know where the lesion is, you could end up without the lesion in your staple line, or with your staple stapling through the lesion, not what you want. So what you can do is you can then readjust your stapler, and you can see that here we definitely got the lesion with a good margin, and off we go, hooray. So she had segments 8 and 9, and it showed a 13 millimeter. It was an atypical carcinoid tumor with a Chi-67 of 5%, and there's a 8 millimeter parenchymal margin. The second case illustrates what I talked about before, which is multiple lung nodules, which is what screening picks up. So this is a 75-year-old man who is a smoker who has been followed up for the screen-detected nodule, and there's a right upper lobe and a right lower lobe nodule, which has grown on interval imaging. His PS0, but his lung function is so-so with a TLCO of 54%. So these are the two nodules. You can see there's a right upper lobe lesion, which is quite medial, and then there is, very inconveniently again, a very subsolid deep nodule in the right lower lobe. Here you can see again the 4 basal segments, medial, anterior, lateral, and basal, and you can see this nodule sits between the lateral and the posterior segment bronchus. So here we need to do a posterior lateral segment, posterior and lateral basal segmentectomy. Anyway, so first of all, we need to know what it is. So we do the navigation bronchoscopy and we biopsy the lesion, and both came back as adenocarcinoma. It's a moderately differentiated adenocarcinoma in the upper lobe and a well-differentiated adenocarcinoma in the lower lobe. And of course, at the same time, we've learned our lesson. We better put 2 fiducials in. So put 2 fiducials in, one there and one there. So that when we come to resect it, we know where it is. There you go, on the X-ray, the navigation bronchoscopy biopsy X-ray, you can see the 2 fiducials, and in the meantime, we wait for the histology, and then it comes back with the adenocarcinoma. So planning the operation, again, planning which segments. So here you can see the 3 segmental bronchus of the right upper lobe, anterior, apical, and posterior segment. You can see it's on the posterior segment bronchus, not far off from the apical segment. But you may think, looking at that scan, is the apical segment, but actually you need to trace your anatomy to make sure that you are absolutely correct. This is a particular problem, very easy to mix up the lingular and the anterior, the upper lobe anterior segmental bronchus, and that's another thing to think about. And then, of course, here's the one I showed you before, medial, anterior, lateral, and the posterior. So we need to do posterior and lateral. And this is Sasha doing it again. He's the best at the robotic surgery. So we do the parenchymal staple line and then turn our imaging on. Remember, I was saying that you need to retract the lung. So you can see this here. You see a staple line here. So this is the nodule, and that's the intersegmental plane between the apical segment and the basal segment. So you lift that up. So you know you've got a margin between your nodule and the apical and basal intersegmental plane. And then you need to know your other segmental plane, which is the one at the front of the lateral segment. And you've got that one as well. So you've got that, you know that where's you're going to, with your clamp, you know where it is. And then you slide your stapler in and you've got that margin and you can staple. So there you go. This is completion of the staple line. You want to move your segment, your 2 segments out, 9 and 10, and you can see you've got the nodule. And this, the reassurance this gives the surgeon afterwards, rather than having to wait for the pathology reports a week later to see if you've got the nodule and you've got a margin, is instantaneous. It's good for the surgeon, it's good for the patient. So the conclusion, the right upper lobe posterior segment had a 6 millimeter margin, and the right lower lobe had a 20 millimeter margin, which is good. So in summary, localizing nodules is increasingly important as nodules come to us as surgeons much smaller. less solid, and deeper. All these make it difficult to use our finger. Using preoperative planning and localization technique allows you to ensures that you capture the nodule. There's no point doing an operation and not missing the nodule, and that you have an adequate resection margin. And for me, I prefer doing navigation bronchoscopy. I prefer endoscopic route. You don't have to. You can do percutaneously yourself too. But it is better for me to let the radiologists get on with what they're good at doing, and I get on doing what I'm good at doing, rather than blocking two professionals' time to do one case. Also, for the patient, it's better not to have to experience a awake pneumothorax as they're waiting between two procedures. Anyway, I have to thank Sasha Stamankiewicz for his contribution to this presentation, because a lot of the work I present in the second half are his. This is Bart's, and you're all very welcome to come and join us as we go on the route to discovering what more to do with these small and difficult lung nodules. Thank you. The patient is better not to have to experience a awake pneumothorax as they're waiting between two procedures. Anyway, I have to thank Sasha Stamankiewicz for his contribution to this presentation, because a lot of the work I present in the second half are his. This is Bart's, and you're all very welcome to come and join us as we go on the route to discovering what more to do with these difficult lung nodules.
Oh, maybe I'm on the wrong.
No idea. How are you?
I'm all right. Are we ready? Suddenly, I've lost my views. We're going next, are we?
I think we're live.
Okay, we're live. Okay, well, thanks very much for Kelvin for this really interesting, very high-tech talk. So many gadgets I would like to have. Well, anyway, so I think Kelvin managed to mention some information about the latest trial that's come out and presented last week at the AATS from Japan. We're going to run a short questionnaire that throughout the next the next half an hour of the session. Please give us your thoughts on that. But more excitingly now, we're going to be joined by Professor Alan Seho, who is a chief cardiothoracic surgery, chief of the cardiothoracic surgery department at the International Medical Center, and he's an honorary consultant at the Gleneagles Center in Hong Kong. He's held many prestigious titles over the time. He was a professor in Tongji University in Shanghai, professor at Hong Kong University, and he's held many prestigious editorial positions, including a associate editor of the Cardiothoracic Surgery, the European Journal of the Cardiothoracic Surgery, and many more. But without much overdue, it's a long CV to go through. Alan, lovely of you to join us. You're going to tell us about your surgical approach for sublobar resection using all the gadgets from open to rats into your famous uniportal vats. Thank you very much, Alan. The floor is to you.
Thank you. Hello, warm greetings from Hong Kong. This is Alan Seho, and I'd like to thank the Society for giving me this opportunity to share with you today. Now, the topic that we're going to be talking on today is surgical approaches for sublobar resection. Now, sublobar resection, of course, today is an increasingly hot topic, and I think it's become a sort of trend around the world over the last few years for increasing use of segmentectomies to treat very early stage lung cancer. Now, as we consider the surgical approaches for this operation, it's very, very important to note straight off why we're actually talking about this in the first place. Why are we doing sublobar resections? And if you really think about it, there's only one reason. And that's because by removing less lung, you're preserving more lung function for patients postoperatively. The only reason we're doing it is to cause less pulmonary compromise. That's very important. Now, looking back over the evidence for segmental resections and sublobar resections, you get many papers like this. This is just one example, which shows that by doing a segmental resection, you actually cause less detriment to the patient's lung function compared to a lobectomy. Here's another study that shows more or less the same thing. The fewer segments you're removing, obviously, you have less loss of lung function after surgery. But if you actually look at the absolute differences in these studies, you find that the actual improvement you get with a segmentectomy is there. It's statistically significant, but in absolute terms, it's not as great as you think. So if you look here in a graph like this, for example, what's the difference between removing one segment or 2 or 3 segments? It's often, yeah, it's there, but it's not that great. Furthermore, when you look at a lot of these studies, often the studies themselves contain areas of controversy or even outright flaws. And I refer you to this very nice paper by my good friend Richard Milton, where he analyzes and says that a lot of these so-called lung function studies comparing lobar and sublobar resections, they do have some flaws in them. And at the end of the day, yes, you do get better preservation of lung function with sublobar resection, but overall, that difference, that advantage is very precarious, and it's something we need to protect very carefully. And that brings us back to the surgical approach. If you're protecting a lead that's that small, then every other little bit is going to help, especially in considering what kind of wounds we're going to make. Now, over the years, many studies have shown that if you do VATS, you're going to preserve lung function better than open thoracotomy. You're well familiar with most of this evidence, so I'm not going to show you all this. It's just a few random studies I'm just casting up here just to remind you of that. But what you'll notice that these studies show is that the degree of improvement you get with VATS over open thoracotomy in terms of lung function is often greater than the improvement you get with a segmentectomy versus lobectomy. And therefore, if you're doing open surgery, you're very likely going to be negating all the advantages you're going to be getting from doing the sublobar resection in the first place. That's very important to know. Here's another study that actually reinforces that point. So you see here, in terms of the DLCO, if you're doing a thoracotomy, the immediate postoperative impact on a patient's DLCO is far greater than with VATS. And that is a bigger difference than you're going to get between segmental and lobar resection. And so I think in terms of considering the surgical approach, the first conclusion we can draw is that open approaches, open thoracotomy, I think, shouldn't be considered at all. If you're going to be doing the segmentectomy, you want to preserve lung function, you shouldn't be thinking about a thoracotomy. It needs to be a minimally invasive approach. Now, of course, as we go on through the evolution of thoracic surgery, we're moving on from conventional multi-port VATS into what I call next generation VATS, needlescopic, 2-port VATS, and especially nowadays, uniportal VATS. On the other hand, if you want to go down the technical route, you can go down the technological route with robotic-assisted thoracic surgery. You can do robotic lobectomies, and of course, you can do robotic segmentectomies. Now, between these two approaches, VATS versus robotics, which should we choose? Now, this is an area of big debate, and there are very many battleground topics where we could debate for this for days. So let's just acknowledge a few things, a few of these battlegrounds, and get them out of the way. First of all, robotics does give you benefits over thoracotomy. Just like VATS versus thoracotomy, robotics can give you better preserved lung function than thoracotomy. Let's just acknowledge that and put it to one side. That's assured. Here's another thing that's assured, and that's the oncological efficacy of robotic surgery. It's just as good as VATS. So we have many meta-analyses and reviews over the years that have shown that with robotic surgery, you can get equivalent number of lymph nodes removed, for example. You get equivalent rates of nodal upstaging. So robotics doesn't compromise that. That's not something we're going to debate today. Another thing we're not going to be debating today is tactile feedback. Critics of robotics say that, oh, you can't feel with your finger. But come on, if we're doing these sublobar resections, the lesions in themselves are already going to be very small. And very often they're going to be ground glass opacities, GGOs, where even if you do VATS, even if you do a thoracotomy, you might not be able to palpate these lesions. So tactile feedback, I think when we're talking about sublobar resections, is not a big issue. If you can't find it, you can always do preoperative localization, and that applies equally to open VATS and RATS. So let's not debate this issue either. On the other hand, another thing I don't think we should be debating is the difficulty of the operation. A lot of robotics proponents will say that, oh, it's actually very difficult to learn a segmentectomy by VATS. Robotics is more easy, it's more intuitive. That's also not exactly true. As myself and my good friend Diego Gonzalez-Rivas has shown over the years, even if you're learning something like uniportal VATS, it's not that difficult. Learning a new VATS technique in Shanghai, we can teach you this in just 2 weeks. In 2 weeks, we've shown that you can acquire advanced skills, you can improve your existing VATS skills quite significantly in just 2 weeks. You can learn VATS or even uniportal VATS segmentectomies in a relatively short space of time. So let's not debate over whether robotics or VATS is easier to learn. Now, we've got all these battleground issues out of the way already. What's left? Now, I want to highlight for you today just 2 areas where I think there still exists some difference between robotics and VATS in terms of sublobar resection. And the first area of debate is value. Now, for those of you who don't know already, what value equates to is the improvement in quality that you're going to be getting with a new technique or new technology divided by the cost of that technique or technology, not only in terms of money, but also often in terms of time. So it's improvement in quality over the cost. Now, in this area, let's have a look. Now, if you compare VATS or robotics with open thoracotomy, you're immediately going to see a better cost efficiency, because when you're doing minimally invasive surgery, you're actually going to be having shorter hospital stays, faster recovery, fewer complications, et cetera, and overall, you're going to be saving costs. But if you compare VATS with robotics, as you all could have guessed, robotics is going to cost more. It's going to cost more because each time you do a robotic surgery, you're going to be using consumables, and these are expensive. They're expensive per patient, and if you multiply that by the number of patients you're going to be doing, the cost differences between a VATS arm and a robotics arm, that's going to add up to quite a lot over a year. Now, that's just the tip of the iceberg, the consumables cost, because on top of that, don't forget, you're going to be having a very significant initial capital outlay just to buy the robotic system in the first place. And every year thereafter, your hospital or your unit is going to be paying maintenance costs on that technological equipment. And this is also quite considerable. On top of that, you also have depreciation costs. Just like buying any new piece of technology, like a new car or a new TV, every single day after your purchase, that unit is going to be losing money through depreciation. And on top of that, you also have training costs, not only of the chief surgeon, but also the entire surgical team, and also the nursing staff, even probably anesthetists. And when you factor all of this in, you have a significant increase in costs whenever you want to do robotic surgery. Now compare this with VATS. This is the set of equipment I use when I perform uniportal VATS segmentectomy. And you can see immediately it's all reusable. They're very cheap, nothing expensive involved at all. So intuitively, you know already that VATS is going to be significantly cheaper than robotic systems. Don't take my word for it, though. Look at what the results say. Yeah, they all acknowledge you have higher costs, but the costs are going to be justified if you have a great improvement in quality. Remember, that's what value is, quality divided by cost. But if we go into the evidence, say meta-analysis like this, when you compare rats versus VATS, there's no difference in surgical outcomes. For example, in morbidity, rats isn't giving you a significant improvement over VATS in terms of quality for all that added cost. And here's another very recent systematic review by our friends over at ISMIX. And they did a comprehensive look at uniportal VATS, robotic, a lot of evidence. And here are the conclusions. When comparing multiport, uniport, and rats, they only found two, I think, relevant features here. One is that uniportal VATS actually gives you less pain than multiportal VATS. They didn't find this sort of benefit with robotics compared to multiportal VATS. On the other hand, as we surmise already, robotics is associated with higher costs. So immediately, in terms of value, you can see that VATS and the newer forms of VATS will always have an advantage over robotic surgery. That's in terms of value. And as I say, don't take my word for it. Look at the results around the world. People are using VATS more. Now, in future, things are going to change. As we all recognize, there are new robotic platforms emerging over the horizon. In fact, some of these systems are already in use now, even in the UK. So not only are they more efficient, more technologically advanced, so that you're improving the quality improvement, moreover, the costs of some of these new robotic platforms are promised to be significantly lower. So the value of new robot systems can be expected to improve significantly in the coming years. So I hope that is the case, and I hope the value proposition of robotics is going to be improving over the next few years. However, having said that, VATS isn't standing still. Some of the key advantages that you have with the robot are now being replicated with VATS. So for example, 3D vision and wristed instrumentation. There are now cheap, effective, low-cost alternatives instruments for VATS that can replicate some of the advantages you can get with robotics. So again, if we're talking about value, well, maybe that improvement in robotics in terms of quality might not be sustained in long term if we can still do this with VATS. As I said, look at what people are actually doing around the world. Using the SCTS survey just from a few years ago, you recognize that in the UK, not that many people have yet converted to using robotics. So robotics is being done, but the number of resections that people are using, using robotics for, that's 30, 34 cases, it's still a very low number. And a lot of that is probably due to value. Across Europe as a whole, again, we're seeing a similar pattern. VATS has really taken hold. In fact, even uniportal VATS is becoming commonplace across Europe as a whole. But in surveys like this, you'll see that robotics doesn't even feature. And again, a lot of that is due to the perceived value of the robotics not being as good as with VATS. Now, Having said all that, there are still some advantages of using a robotic system. And again, I refer you to this excellent paper by my friend Abbas from Pennsylvania. And he lists a lot of potential advantages of using robotic surgery. But a lot of these advantages, again, I've said already in the last few minutes, we've already dismissed. And for me, there are only two areas where I think there is an advantage with the robotic system that might tempt me to change to using robotics more. The first is in the applicability in morbidly obese patients. However, in Hong Kong, where I practice, I'm probably the most obese person I know. So the applicability of robots in obese patients is extremely limited. It's an advantage that you almost never actually apply in real life. So let's get that out of the way. The remaining advantage of a robotic for sublobar surgery, I think, is hugely significant. And this is the second area of difference I want to highlight between rats and VATS. And that's the imaging systems, especially the Firefly imaging systems. Because today, with the Firefly system, with the robotic system, you can get images like this. Now, with this autofluorescence, with the indocyanine green dye that you can apply, you can not only identify the lesion itself on table very accurately, very conveniently, you can also identify intersegmental planes. And that's a tremendous advantage when it comes to doing a segmentectomy. This is something that really I would be tempted to use to change the robot for simply because of this. It's huge. But on the other hand, this is another advantage which may not persist. Today, we're seeing the robots being used more and more for segmental resections because it is quite useful. But as times improve and technology improves, we're already seeing similar systems being applied in VATS. So you can already, side by side, use pre-op CT imaging next to your VATS views. So this partially negates the advantages of the Firefly system. Moreover, newer developments with the scopes are emerging. This is a paper I find very interesting from Japan, where they can actually track the movement of the thoracoscope and the VATS instruments during an operation. And if you can track the movement, then you can actually track the image you're seeing on screen as the scope moves around. And you can overlay CT information onto that video information. You can see there on the left-hand monitor in the picture A, and you can see with the scope vision, the 3D rendered image, for example, where the tumor has invaded into the underlying chest wall. And that can help you do very precise surgery even beyond your direct visual range. So with improvements in video technology, even some of the advantages of the robot in terms of imaging systems can potentially be negated. So this is an area of existing advantage of robots. Maybe in future it might be changed. However, having identified value and imaging as two areas of differences between VATS and rats, I do want to close by saying that we shouldn't only be thinking about competition amongst ourselves over the best surgical approach. The biggest competition in this field of thoracic oncology is the non-resectional therapies. This is where the challenge lies. We're doing these sublobar sections for these small lesions, but these lesions are, again, precisely the kind of lesions that are going to be amenable to things like SBRT, immunotherapy, ablation therapy. And these are already emerging on the market today. They're already very attractive to patients because there's no incision, no resection involved. And increasingly, they're being shown to be highly effective in selective patients. Now, I don't think we should be competing amongst ourselves. I don't even think we should be competing with our non-oncology colleagues in a malignant way. There should be competition so that we improve the care we're offering to our patients. And out of this competition, hopefully something good will emerge. but we shouldn't be fighting over each other just for the sake of fighting over things. In conclusion, regarding a surgical approach for sublobar resection, I just want to say these few words. I think we must remember that the only reason we're doing sublobar resections is to preserve lung function. That's the only thing segmentectomies are giving us. Now, if we're considering that, then first of all, I don't think open surgery should even be considered, because it negates the advantage of sublobar resection. If wherever possible, you should be doing this by a minimally invasive approach. Today, that still represents the best value, i.e. best improvement in quality over open surgery divided by costs, simply because VATS costs so little and it's so easy to learn. That's true for now. With newer robot systems in future, this calculation might change. With rats, the key advantage of rats today for sublobar resection is the unparalleled advantage in terms of visualization, especially in overlaying preoperative imaging data, especially with the use of autofluorescence imaging to help guide segmental resection with the robots. And that's a great advantage. Again, for now, because with improving video technology we're getting already, maybe in future some of these benefits can be replicated with newer VAT systems. However, the overarching sort of narrative should include the fact that future challenges will come from non-resectional therapy. So as we improve the surgical approach for sublobar resection, we must always be aware that non-resectional therapy is the key consideration in the minds of most of our patients, and we as thoracic surgeons need to prepare for that. So with that, I'll end my talk and welcome any questions. Thank you very, very much.
Can you hear me? Thank you, Alan, for that thought-provoking discussion on the limitations of VATs and rats and the challenge we're facing with non-surgical options. Just before I introduce Dominic, I'd like to encourage the participants to take part in the poll on Slido about the practice changes that may be stimulated by the recent Japanese study, randomized controlled trial on segmentectomy, and what they've heard this morning. Moving on to the last talk, and for me, one of the ones I've anticipated all morning, I'd like to introduce Dominic Gosso. I hope I've said that right, from the Institute in Montsouris in Paris, who is a well-known surgeon from France with 378 publications, many of them on the role of segmentectomy versus lobectomy. And I'm sure he is very welcoming of last Sunday's publication from Japan, and has taken part in the two meetings on sublobar resection in 2018 and 2019, and presumably in Japan in October. Dominique is going to tell us about, we've heard about the evidence for segmentectomy, how to localize it from Kelvin, the approach, and from Alan, and I'm hoping that Dominic will give us some technical tips and tricks about how to identify the intersegmental planes and deal with the vessels, particularly the veins for me, which sometimes are difficult to identify, go into each segment. Dominique.
Many thanks for the invitation to talk in this interesting session. So I was asked to give a short presentation about how to manage the intersegmental plane during sublobar resections and how to deal with the vessel control. Here are my disclosures. I got fees from Medtronic Company, Delacroix Chevalier Company, and Olympus. So the presentation is based on the experience of our hospital. As you see, the number of sublobar resection and the rate is rising, except this year due to the pandemic, of course. So the first part of my presentation would be how to deal with the vessels. I will divide this part in two, how to deal with arteries and how to deal with the veins. With arteries, I think it's now very clear that 3D modelization or 3D reconstruction is not only helpful, but sometimes mandatory to prepare the procedure. So just to give you an idea about how important is this 3D reconstruction, here is our evolution in the department. So when I started this surgery about 10 years ago, we didn't use any 3D model, and we faced some problem. We were sometimes lost during the dissection, and so we asked our radiologist to perform for us 3D reconstruction. At that time, it looks like this. It was not so bad, but of course, now it looks a little bit primitive. And after a couple of cases, something like 50, we thought we were mastering these procedures and we didn't ask for a model anymore. And again, we got some problems. And now we always have a 3D model, at least for all complex segmentectomies. But of course, it has nothing to see with the previous 3D. Now it looks like this. So the advantage of the 3D reconstruction is that you can navigate through the model. You can make a virtual safety margin. And most important, you can navigate layer by layer. So you can choose to remove the veins or add the arteries or add the veins, whatever you like. So we have the 3D reconstruction in the operating room on a large screen. We also have it on our computers and smartphones. Just an example to demonstrate that there is usually a perfect match between the 3D model and the reality. So this is the small V2 transversal V2, and this is how it looks like during a thoracoscopic procedure. So if you're not so much familiar with this 3D model, you may ask, what is the real benefit? I just give you an example. Let's figure you are performing a partial basilar segmentectomy of the lower lobe. You know that according to the Nomori and Okada Atlas, usually A8 and A9 plus 10 are two different trunks in about 90% of the cases. But even if you try to perform an extensive dissection with a clear view, at a certain point you are lost because you don't have any view on the distal part of these arteries. And to know what's happening at the distal portion of the lobe, you have to rely on the 3D model. And it's getting now clear that finally you have a separate A10 and a common trunk A9, A8. You can also detect on the 3D model some arteries that are not easy to see during the procedures, like in A7, for instance, and you can turn around the model. And here it is. And here it is during the procedure. Let's figure you are performing a so-called easy segmentectomy, like a lingulectomy. You know that usually there are two arteries, and sometimes you get three. You may presume that this artery is for segment 3, but it's much better if you can see it on the 3D reconstruction. Again, during lingulectomy, you know that in about 20% of the cases, you have this big mediastinal lingular artery. It's not a problem. You can find it without having the 3D model. But in some cases, from this mediastinal lingular artery, you can have an accessory branch to the segment 3, and this is almost impossible to detect during the procedure. So if you don't have the chance of having these 3D reconstruction for arteries, the only choice you have is performing an extensive dissection in the fissure. And so if you want to have a good arterial control, I don't see any other option than opening the fissure. And of course, I think that for segmentectomies, there is no place for fissureless techniques. Now, let's switch to the problem of venous control. For the veins, the issue is somewhat different than for arteries. The main concern is where to control the vein, at which level, in the hilum or in the parenchyma. For the upper lobe, the pattern of the veins is almost constant. For instance, here for the left lower lobe, it's almost constant. The only difference is that sometimes the lingular vein can be a little bit tiny, and so the lingula can be at risk of venous ischemia if you are performing a trisegmentectomy, but usually it's almost constant. But for the lower lobes, it's the issue is totally different. So according to Nomori and Okada, the classical pattern for the inferior basal, the inferior the lower vein of the inferior lobe is a V6, a superior basal vein for segment 8, and an inferior basal vein for segment 9 and 10, like this. But this is not so frequent. It's about 15% of the cases. In many cases, you have totally different pattern. And so if you figure, for instance, you are performing a segment 9 plus 10, you cannot take the risk of dividing this whole branch. You have to take care. If you are performing segment 6 on the left side, for instance, usually it's seen as an easy segmentectomy, but again, you have to take care. You may think that this is the vein for segment 6, but if you look carefully, you see that there is a branch coming from one of the basilar segments. So the level of division should not be here, sorry. It should not be here, but here, as you can see here on the intraoperative view. So you have to divide the V6 here and not here. So should we control the vein at the level of the hilum or in the parenchyma? According to the atlas of Nomori and Okada, they say that it's very dangerous to control the venous branch in the hilum, and agree with them. This should not be done. It's safer to control the vein in the parenchyma. And for instance, if you are performing here a segmentectomy 8, you have divided the branches of segment 8, the bronchus, and you see here the vein. This is the level you have to divide it here. Just last thing with the control of the vein, you have to take care during stapling. So this is during a left basilar segmentectomy. You can see that the stapling is nice. The vein is for segment 6 is perfectly clear, but here you have some doubt about a compression of the vein. It's not quite sure, but it may be more or less compressed by the staple line, and this may be a cause of postoperative ischemia. So in conclusion with this issue of vessel control, I think that for artery, what is very important, at least for complex segmentectomy, is having a preoperative 3D modelization. In any case, even if you have this model, you must perform an extensive dissection in the fissure. For venous control, of course, the 3D model is very helpful. Controlling the vein in the hilum is a bit dangerous. It's safer to control it in the parenchyma, especially for the lower lobes, and take care during stapling. in order not to injure the vein. Second part of this presentation is how to deal with the intersegmental plane. I think we all agree that thoracoscopic sublobar resections is a new challenge for us, something that we find sometimes very difficult. But there is a challenge inside the challenge, which could be called the sub-challenge. It is the issue of the intersegmental plane. So what is this issue? The issue is that you may have a nice 3D model with nice colors, but for instance, if you are performing this segmentectomy 3 on the right side, but unfortunately during the procedure you have no color. So when you have control of all the vessel and bronchi, you don't know if the intersegmental plane should be divided here or here, for instance. Sorry, I have problem. Yes. So you probably know the classical way of delineating the intersegmental plane by inflation, deflation. Here are two examples during an S6 resection and basilar resection. And this is an example where inflation deflation method looks very nice. So the plane is here, but this is quite rare. Usually it doesn't work like this because, as you know, there are the cone spores, the canals of Lambert, so that when you are reventilating the lung, you don't know exactly where you have to put your clamp or your stapler. So this is an example during apicoposterior right segmentectomy. You see here the marks that are made by the clamp. So it seems that the surgeon is hesitating between clamping and stapling here or here, finally here. And in addition, this ventilated segment 3 can be cumbersome during the end of the procedure. So another method of inflation deflation has been described. It's the reverse method. Instead of ventilating only the segment to be removed, you ventilate the whole lobe and then clamp the bronchus and deflate the lungs, so that only the segment you will remove remains ventilated. It's a little bit more accurate than the conventional method, but still you have the issue of a ventilated segment, and it's not very accurate. This selective inflation of the segmental bronchus has been described. You have used it in 2 or 3 patients and have given up for several reasons. So here this is during segment 2 on the left side. And the reason we have given up is that it's impossible to know whether your catheter or needle is in the segmental bronchus or in the subsegmental bronchus. And in addition, there are some dangers and complications that have been described because the catheter or the needle can puncture a vessel behind the bronchus, and serious embolism have been reported. We have tried marking either of the segment or of the adjacent segments by electromagnetic navigation. We also have given up. It was not very accurate. You see here that the limits are unclear. It's time consuming, and we don't do it anymore. So now our favorite method is the use of near-infrared imaging after a systemic injection of indocyanine green. You know that this ICG binds with the proteins of the plasma, and when you stimulate it by a laser, that emits a fluorescent light that appears usually in green. for those who might not be very familiar, this is how it looks like during basilar segmentectomy on the right side. And so you see that the remaining segment 6 capture the ICG while the basilar segments remain normal. The success rate of ICG is reported between 88 and 98%. It's quite high. There are, however, some failures, usually with patients with severe COPD, because the vascularization of this patient is poor, and so the distribution of ICG is not homogeneous. Another example of failure here. There are no adverse events, or very rare, and the ICG is eliminated by the liver, so you have to take care in patients with hepatic insufficiency. Just to see how accurate it can be, so this is during a segment 9+10, and we were surprised to see that we didn't understand why there is a part here that didn't capture the ICG. And the reason was that a small artery had been clipped because of an injury during the procedure, and this corresponds to this devascularized zone here. Some samples for those who are still not very familiar with the use of ICG during S1 on the right side, S1+2. Okay, this is a case where we performed 2 segmentectomy, S2 and S6, on the same patient for 2 small T1A carcinomas. And if you don't have a 3D model and you are not very sure of which vessel to divide, you can use those bulldogs that we release inside the chest cavity and perform the test with the ICG. I was interested by this article published 2 years ago, showing that when you are using ICG, the intersegmental plane is usually very different from that was predicted by the surgeon. And you have a better margin, a better safety margin, as you can see here. And this is illustrated by 2 examples I can show you here. So you are performing a lingulectomy. The clamp has been applied before stapling. So this is the direction, the supposed direction of stapling, which actually should be applied here. Another example, segment 6, you apply the clamp in this direction, but actually the correct line is that one. For segmentectomies of the lower lobe, the complex one, it's almost mandatory to have a marking with the ICG, because stapling can be very tricky. The issue of stapling the basilar segment has been well demonstrated by Masaki Sato. So he says that sometimes the stapling is linear or V-shaped like this, but for the lower lobes, it is what he is calling stereo stapling, or Mercedes-Benz sign stapling like this. And it took us some time to understand how to do that. Now that we have ICG, I must say it's much better. And once you have applied the dots after injection of ICG, you can perform the stapling. Another trick I give you is that if you are just starting with this complex segmentectomies of the basilar lobe, you may be tempted to use 60 millimeters reloads. Don't do that, at least at the beginning of stapling. Use short reloads, 30 or 45, and progress step by step. that makes finally the procedure easier. So I come to the end just to say that when you are performing these procedures, there are some parts of the procedures that depend on the surgeons, like the quality of dissection in the fissure, the quality of lymph node dissection, dissection of the intersegmental lymph nodes, I mean, but there are many other points that depends also on the technology, like having a good 3D reconstruction for the anatomy, being able to localize the target, for instance, with the ENB, having predicted the safety margins, and having the right technology to delineate the intersegmental plane. That's all I wanted to say, and hopefully if we can keep quiet with the pandemic, maybe the third edition of the Sublobar resection conference will happen in October in Yamagata, Japan. Thank you very much for your attention.
Well, thank you very much to all the speakers. It's a very, very interesting time for thoracic surgery. I remember the old days where the cardiac surgeon would do a pneumonectomy on the right or the left. But we've certainly moved on now. I'm so happy that we're now learning the true bronchopulmonary anatomy of the lung and applying it to treat our patients. I'm sure we're going to have a lot of questions. I think Hazem is fielding those. So let's go, Hazem, with some questions before lunch.
Yeah, I'm mindful, been instructed by the highest forces in the land not to drag on the Q&A too long, to respect lunch on my hotline between me and them. Right, we've got very intriguing questions. Thanks for everyone who's contributed to this survey. I'm gonna pick up with a question, well, a comment from Eric, as ever. He's making a point about segmental margins are defined by the bronchus and the vein, and what he's saying, deviating from that tend to render our segmentectomy a fancy wedge. And I guess that probably get Calvin to have a stab at this, whether he's agreed with deviating from these sort of strategy to define the plane, or maybe Dominic as well. Here's some opinion from
Kelvin, do you want to comment?
I can't, and I might. Can you hear me? Because I get this spinning circle. You can hear me, okay?
Yes, we can hear you.
Okay, so the question is, well, I mean, to me, as I said earlier, I think to me the importance of the intersegmental plane is more the marginal plane, and that plane to me is flexible as long as you get a margin. But Dominic is probably much more experienced in the detail of the planes.
Well, I think there are two issues actually that are somewhat different. One is the intersegmental plane itself, and one is the target nodule. And this is why it's very important to have a preoperative localization of the target, because, for instance, let's take the case of a nodule that is at the lower part of segment 6. You want to perform a segmentectomy S6, but the nodule is at the lower part of the segment. So even if you have a good margin that is delineated, for instance, with ICG, if you are too close to the nodule, your margin will not be sufficient. So you have to rely on the preoperative modelization and on ICG, if you are using ICG, but also on the precise location of the nodule. And this is why the technique developed by Kelvin is very interesting, because even if you are sure that the nodule is in segment 6, it's interesting to have a marking of the nodule, so that maybe you can deviate a little bit with your stapler to remove more parenchyma and have a 2 centimeter margin.
I'm seeing lots of nodding. My views are also margins are more important than anatomy in this setting.
If I may add something, I think it's extremely important to have a frozen section on the margins. Well, there are a few cases where you are sure to be far away from the target nodule, but sometimes we were very surprised, and we had an answer of the pathologist saying it's suspicious, the margin is suspicious. And so you cannot rely only on your eye. You have to have a frozen section on the margin, and for us also on the intersegmental lymph nodes.
In fact, I think Sato coined the term extended segmentectomy. So the question, is it a wedge or a segment? Actually, it is still a segment, but a better segment because you've extended it.
Yes, another question from Chris Sato to this time to Peter is: are you aware of any evidence showing that limited resection with the increasing support to it in terms of survival would improve our resection rates?
Well, just last weekend, we learned from the JCOC 0802 trial that it's actually very supportive for sublobar resection, at least in the Japanese group. My concern, whether or not this will disseminate in the thoracic community, is the issues raised by Dominique Gossot. It's very difficult, and is it externally validated? That will be one of my concerns, because as Alan was saying, the only reason to do a sublobar resection is to preserve lung parenchyma, and would you rather have a poor sublobar resection anatomically or a better lobar resection from an oncological viewpoint? That needs to be discussed. So now we have evidence in favor of an anatomical segmentectomy. It will be very interesting to see the result from the North American trial that included the wedges in the sublobar group, if the results are consistent.
Lots of very good questions throughout, but the time is very, very limited. A question to Alan, and that's from Oxford about, and I'm trying to remember who, from Elizabeth, asking, are segments or equal, or some more equal than others? In a way, do you share the concern about some more basal segment associated with high recurrence rate? And she's also asked the rest of the faculty to have their opinion on that.
Yeah, good question. And in the interest of time, I'll keep it short. We all recognize that not all segments are the same. There are the so-called simple segments, which everybody can do, and the complex segment techniques. The complex segment techniques, the problem with them is that unless you're very skilled, you're not going to get very good margins. You're probably going to have more complications, more air leaks. In that kind of situation, if you're still not yet a master like the other speakers here, you should be questioning whether you're should be doing those. As we saw, even in the JCOG trial, the margins of advantage for a segmentectomy over lobectomy are actually quite marginal, even in terms of lung function preservation. So unless you're doing a very good job, and you're a master of those complex segmentectomies, probably lay off. The other thing that we should be thinking about is things like these multiple segmentectomies, these tri-segmentectomies, for example. The more segments you remove, you're edging towards a point when you're not actually preserving that much lung function. And as I say, that's the only point of doing a segmentectomy. If you're not preserving a lot of lung function, maybe you should just go ahead and do a lobectomy. That's just my view.
David wanted to say something. David?
Can you hear me all right? So on Tuesday, Melinda's asked me to give a short talk on the implications of the JCOG trial. For me, and it will be called Less is More, I'm not too interested in what we're taking out as to what we're leaving behind. And I think my interpretation of the JCOG trial is slightly controversial. I'll try and explain why I think the survival is greater, but the recurrence is higher. When I do volume reduction with ICG, I do see underperfused lung due to COPD. Now, when I'm doing a lung resection for cancer, I have no problem about taking that out. So there may be little point in doing an S1 of the right upper lobe in a COPD patient. In fact, they may be better off with an upper lobectomy because of the volume reduction effect. So I think we have to be more intelligent than just bovine anatomists. We are physiologists, surgical physiologists, and what we are doing is trying to preserve as much functioning lung parenchyma while obtaining oncological principles. And that is the basics of what we're doing. And I think a lot of these discussions should focus on those things. What Dominic has said is absolutely correct. What Alan's alluding to as well. You don't need to preserve lung that the patient will be better off without. And there's no need to compromise oncology to do that.
That's great. I think we're probably going to have to close here. Thank you very much for all our eminent faculty and chairs members who's given us a very informative and yet mind-provoking session. The quest is carrying on, I guess, to redefine the new gold standard, or the gold standard for lung resection in lung cancer. I think look at for the results of that survey and that poll. I think is very interesting. And then hopefully we will meet again when we have more data coming and the paper is out from Japan. Enjoy your lunch, and we'll see you throughout the meeting, hopefully. Thank you very much.
Bye-bye. Bye, everyone.